Right. Okay, welcome to the 8th session today. And today's topic is vaginal birth after cesarean. Right? Now, it's called VBAC also because we meet it a lot, and it is one of the cases that you will need to discuss during your questions. It's one of the commonest cases given for you for your examinations, right? And you will need to know a few facts about it for you all to be able to do well, right? And it is one of the most commonest cases actually we find for your examinations as students in MBBS. If you are in Sri Lanka, you will you have to do a clinical case, so therefore this is one of the commonest cases. Right. Now, why is this important? Strangely, there was a time some time ago where when a lot of couples wanted cesarean sections, right? Quite a few of them would, the first thing they would, doctor as a, can I have a cesarean section? So the request was quite sort of prominent, maybe 3, 5, 6, 7 years ago. There was a time when a lot of women had cesarean sections and they were on request. Most of these cesarean sections were done in the private sector where the woman could have requested, while in the government sector, not so much, because like in UK, you cannot simply have a cesarean section unless 2 consultants thought that it was necessary. So usually it is not offered as routine. Now, the trend, luckily, and it has changed. So there's hardly, very, very rarely, we get a couple requesting for a cesarean section, which is very good. So everyone seems to be, especially the younger generation, is geared towards having a vaginal delivery, which is an extremely good trend. So therefore, we are experiencing now a lot of women who are requesting for vaginal deliveries. The other reason what I think is that now we are offering them in most government institutions and in the private sector as well. We are offering them epidurals, which is actually facilitating a lot of vaginal deliveries. The reason being, one of the main reasons a woman is afraid of a vaginal delivery is pain, and rightly so, because pain is something that you cannot gauge that pain probably, and I have never experienced it, and I never will. But it's supposed to be one of the most excruciating pains a human being can experience, and therefore, with a very good epidural, that pain can be cut off by about 90-95%, and therefore the women with good epidurals will smile through delivery, right? They will sit around, read if they want, smile, chat, and so therefore the epidurals now are walking epidurals, where in the sense that the motor functions are not cut off, only the pain sensation is cut off, so they can be mobilized during labor, they can go up and down, walk, and therefore they are not immobilized, and therefore the advantages have become better and higher now, right? Okay, so all in all, from there stems the requirement or the necessity for women to have a vaginal birth even after a cesarean section, and therefore the request is coming up more and more, and therefore we need to know how to handle it, when to, and how to discuss that with these women who are requesting for a vaginal birth after cesarean, right? Altogether, there are about, I think, depending on unit to unit, place to place, The number of cesarean sections or the percentages vary, but anyway, it fluctuates from somewhere between 20% to 40%, depending on the profile of the hospital. Obviously, in units which are handling a lot of complicated obstetric cases, okay, like medical problems in pregnancy or any other complicated cases, the cesarean section rates will go up, right? Because the more complications that there are, the higher the chance of having a cesarean section due to maternal or fetal considerations. If that particular unit is handling low risk labors, right, without many complications and or any complicating diseases, then the chances of the cesarean section is lower. And therefore, just by looking at the unit and saying, okay, here in this hospital, a cesarean section, right, and in other hospital, somebody is suddenly making noises. Okay, I will mute. Right. And having cesarean while looking at another unit and just comparing the cesarean section rates is not a good enough thing. You need to compare the number of deliveries, the number of complicated deliveries that unit does, the number of problems that it handles, and therefore only then we can compare them depending on their types of problems that they handle, right? Right. So all in all, what is advantages in a vaginal birth after cesarean? So the main thing what we have to remember is, if a woman goes for a vaginal delivery after cesarean, the chances of the mother having problem is quite low, right? And when you compare that with a normal delivery, the differences are not much in a woman who is going to have a vaginal birth without any cesarean section, or a woman who is had a successful vaginal birth. The morbidity is not that great, right? The chances of if you go for what is called a elective repeat cesarean section, what does that mean? If a woman comes to you with a past cesarean section and you go for an elective section, that is called an elective repeat cesarean section, or ERCS. Right? The chances of morbidity is higher because elective cesarean or cesarean section itself, when compared to a vaginal delivery, the chance of morbidity is higher because it's a surgery. Anesthesia has to be there, infections can get in, so it's a surgery. And even if you compare, for example, vaginal delivery, and the chance of the woman dying is about 4 in 100,000, right? If you go for a cesarean section or an elective cesarean section after or elective repeat cesarean section, the chance of the woman dying is 13 in 100,000. Okay, due to different types of complications. But at a glance, on face value, right, the morbidity you have to understand is lower in a vaginal birth after cesarean when compared to a elective repeat cesarean section. Okay, but there are some things that there are maybe problems with the vaginal birth after cesarean, while in a repeat elective section, some of the problems are less, which we will discuss slowly. What is most important is that what we have to understand is that a woman who is attempting an vaginal birth after cesarean, and then if she has to go for a emergency cesarean section, then her morbidity goes up very high. right? So therefore, if you look at a repeat elective cesarean section, the morbidity, the overall morbidity can be calculated about 0.8%, right? But while in a successful vaginal birth after cesarean, it's even less, right? While if you go for a vaginal birth after cesarean and it fails, and we have to go for an emergency surgery, then the morbidity goes up to 3.8%, about 3 to 4 times more than that. You all understand? So the problem lies in the group that the vaginal delivery after cesarean becomes unsuccessful, and then it's a failed vaginal birth after cesarean, and then you have to go for an emergency delivery, and that is the problem which we need to understand, right? Where the morbidity is high. Okay, so that is what you have to understand. So if you look at the terminology in this, you need to think of both three things. You have to understand three things very well. What is it? One is vaginal birth after cesarean, which you are talking about. Okay, so that is a woman has had one or many cesarean sections, right, which we will discuss later. And then the woman has a vaginal delivery, so it becomes a successful vaginal delivery after cesarean. Then we have another definition which you need to understand. What is the second definition, children? It's elective repeat cesarean section. So we just do another cesarean section because she has had one cesarean section, one or two or three, doesn't matter, cesarean section. So it's called a elective ERCS. Okay. The third entity we have to understand is an unsuccessful or a failed vaginal birth after cesarean, and the delivery would mean that it is an emergency cesarean section. So if they had to go for an emergency cesarean section, trying to go for a VBAC, then of course it is a fail. And that is the place where all the morbidity comes out. More than the vaginal birth after cesarean, more than a repeat elective cesarean section, the morbidity becomes high if you have to rush them into the theater for a cesarean section, right? Okay, give me a moment. I'll take a call. Okay, sorry. Right. So now let's first of all, that is the introduction. Now, first of all, let's look at something. Let's look at the time where there are contraindications. Where do we not do vaginal birth after cesarean? Because if a woman has these contraindications, then you go definitely for a repeat elective cesarean section, right? Number one, if there are any indications to go for a cesarean section anyway, okay? For example, if there's a lower segment fibroid which has developed, if there is a major degree placenta previa where the placenta is covering the cervical loss. So if there's an indication that we have to go for a cesarean section anyway, then of course a vaginal birth after cesarean is not indicated. Okay. The second thing is if she has had a classical incision on the uterus. What is a classical incision? It's an upper segment vertical incision. So you know that the uterus has an upper segment and a lower segment, right? And the lower segment is usually formed after about 32 weeks, 34 weeks. From 28 it starts to form, but near 32, 34 it starts to form. By about 36, 37 it is well formed, right? It becomes thin and ready for delivery, right? But an upper segment cesarean section is where it's done on the upper segment and it is vertical. So the chances of scar rupture during labor, because most of the ruptures are during labor, about only a small percentage will be found after delivery, but usually most of the ruptures are during labor, and about 8 to 10% are during the final stage or the second stage, but most of it is during the normal first stage of labor, right? So if there is a classical cesarean section done on the uterus, which is the upper segment vertical, the chance of scar rupture is up from 4% to 9%, which is very high, close to 1 in 10. Yeah. So therefore, we do not attempt a vaginal birth after cesarean if she has had. And where do you find that children? Where do you find the information? The diagnosis card. All right. The second thing is, if the woman has had a relatively different incision even on the lower segment, we need to be very, very careful when you are deciding. In the diagnosis card, you will see it. Sometimes when the baby is difficult to deliver, we do what is called a J incision. So see, the normal incision is like that, yeah, and then one side can be extended right up, and it looks like a J on the uterus, right? When we want a bigger. If the baby gets turned inside, the baby gets stuck, and sometimes the baby turns inside and it's difficult to deliver. Sometimes you try to put the forceps, the baby's head moves away and becomes transverse. The amniotic fluid leaks out, and the uterus clamps down on the baby, and it becomes extremely difficult to sometimes deliver, right? So you can't find the fetal path sometimes, and you can't deliver it by head or by breech. Then sometimes what happens, what we can do is just make the opening bigger. How do we do that? We just take the scissors and cut and make the incision a J incision. And why J? Because we can't extend it onto the lateral sides, because the uterine arteries and all the blood supply is on the lateral side. So therefore we extend it up like a J. Those plus in great difficulty, one of the things that we might do is to put a T incision. So the normal incision is like that. Then you just do another cut right in the middle, open it up like a flap, and then get the baby out. But then when we suture, the most least place supplied blood between the where the T incision or the three things join, right? Where like that here. So therefore, that is the place that can rupture most. So therefore, if she has had this, then of course we will try to avoid a vaginal birth after cesarean. The next contraindication is if she has had a myomectomy in the past. Okay, especially if the cavity has been opened into and multiple fibroids have been removed, right? So therefore, during these, if there has been a past myomectomy, we will try to avoid a vaginal birth after cesarean. Of course, if the fibroids are more out there, outside or subserosal and not open into the cavity, right, or pedunculated, of course, these women can undergo a vaginal birth after cesarean, but the notes must be very clear, and that is why the intern house officers, where most of the people which I see are going to be intern house officers, hopefully in the future, right? And especially if you are giving out diagnosis cards are written out, please remember, especially for myomectomies, make sure you write whether during the surgery the uterine cavity was opened or not, because that is very important for us to decide whether the woman can go for a vaginal birth after delivery, right? Then the more cesarean sections the woman has undergone, then of course there are contraindications for a vaginal birth after cesarean. So in this case, of course, we need to discuss whether vaginal delivery after cesarean is possible after 2, 3, 4, 5, 6, or 7 cesarean sections. There are women who have had multiple cesarean sections. I remember the highest one I have done is the 8th cesarean section in a woman who has had 7 cesarean sections, right? And that was a lady from France, a French lady. When I was working in UK, she has visited. She was visiting UK and she went into labor, came in, and so she had a 7, 8 cesarean section. I don't know, there were no additions inside, so probably she and she said, no, please don't sterilize me, I want to make another few more, right? So therefore no sterilization was done. So what you have to remember is, when you are looking at vaginal birth after cesarean, after 2 cesarean sections, all the trials up to now have shown that there is no huge difference between having a vaginal birth after 2 cesarean section and having a vaginal birth after 1 cesarean section. So that is what the trials have shown. However, it has been also shown in the trial, the chances of a cesarean hysterectomy goes up if you try for a vaginal birth after 2 cesarean sections, and the chances of blood transfusions go up, and the chances of other like endometritis problems will also go up if she has had past 2 cesarean sections. So past 2 cesarean sections is not an, what it is, automatic contraindication for cesarean sections for a vaginal delivery. But however, in Sri Lanka, we are more cautious, right? And usually we are more cautious. And usually in Sri Lanka, if there were past 2 cesarean section, the woman probably would go for a elective repeat cesarean section. Although literature suggests that it is also a possibility, so you need to keep that in mind. However, when it goes to the 3rd, 4th, 5th, 6th, 7th, especially after the 3rd or the 4th elective section, what happens is the chance of mortality and morbidity will go up, right? And especially if the placenta is overlying the scar, the chance of abnormal adherence of the placenta goes up with each subsequent cesarean section. And therefore, we need to be very, very careful, especially if the placenta is just over the uterine scar, to think about whether we need to try to go for a vaginal birth after cesarean. Overall, remember, your country and your unit can draw the lines as to where, or your consultant, or it can be a consultant decision where you can say, okay, say after if there are past 2 cesarean sections, then it's better to go for a elective cesarean section this time. So that is the normal understanding in Sri Lankan units, most of the Sri Lankan units at the moment. So therefore, although it can change with time, but remember, the evidence shows that other than an increasing risk of hysterectomy and blood transfusion and a few more things, the success rates and the problems are almost the same as a past single cesarean section. Is that clear, children? So those are the contraindications which we need to think about when we are going for a vaginal birth. So with those, we don't do it, right? And of course, if there are different things, for example, if there are malpositions, right? If there are say breech or twin pregnancies, sometimes you might need to call it a relative contraindication, although there is not much evidence to say that you should not try, right? So say if it's a preterm, but most of the preterm deliveries, if it is a past cesarean section, right, then you can go for a vaginal birth after cesarean if they go into spontaneous labor. The other contraindication you might want to consider is if there was a past uterine rupture, right? So say she has had a uterine rupture, and then she comes to you now and she says, okay, I want a vaginal birth after cesarean. But however, if she has had a past uterine rupture, then of course, it might not be a very good idea to consider a vaginal birth at this point, because uterine rupture can recur and the baby and the mother can die in that case, right? So those are the contraindications. The other contraindication I have said about 5, 6, right? The other contraindication we have to remember is if it was a hysterotomy in the past. What is a hysterotomy? Is where an cesarean section is carried out for any other reason less than when the period of gestation is less than 28 weeks. What does that mean? If the period of gestation was less than 28 weeks, the incision which you are putting on the uterus will always be on the upper segment at that point, because there is no lower segment, upper segment at that point. So if you do a hysterotomy at 24 weeks, the uterus will not be so large. So whatever cut you are going to put in is going to end up in the lower segment, upper segment in the next pregnancy. You understand? So basically you are having a vertical upper segment cesarean section scar. If you have done a hysterotomy in the past and this present pregnancy, probably the scar might be in the upper segment, right? So therefore, it is like as if we are dealing with the upper segment scar, and therefore these chances may be higher, and therefore it may be a relative contraindication for a repeat elective cesarean section. Is that clear, children? Right? Any questions that you want to ask so far from anything? Right? Right. Okay, now from there onwards, let's move on to two large areas, right? One area is what are the things that will contribute towards a successful vaginal delivery or a vaginal birth after cesarean. Okay, so these are the things that you look at in the history, and these are the things that you will look for in the woman, and these are the things that you are going to try and find in the notes in the woman, okay, where you can make an informed choice, or you can tell the woman, okay, these are the reasons, right? Number one, so if the woman has had a vaginal delivery, and then she has had a cesarean section, right? And then she comes to you for her third section, which means in the past she has had a vaginal delivery, right? That means the chances of the vaginal birth after cesarean being successful is higher. Okay, so past vaginal delivery, there is a possibility that it can be higher, right? The next thing is, what is important is, if she has had a successful vaginal birth after cesarean previously, the chances of having a successful vaginal birth after cesarean this time is also high. Okay? Got it? The third thing, if the baby is of a normal size, right? That is less than, say, in Sri Lanka, probably we should be calling it less than about 3.5 kg or even less than 3, right? So if the size is normal, the chance of having a vaginal delivery is better. If the head is engaged, head has gone nicely into the pelvis, the chances of a vaginal birth after cesarean becomes higher. Okay? If at presentation, if the cervical os is more than 4 centimeters open, or the Bishop's score is very good, the chance of having a vaginal birth, successful vaginal birth after cesarean is very good, right? Then, if she is not overweight, especially if the BMI is less than 30, the chances become higher. If she is younger than say in a 30s or 20s even, right? The chance of a vaginal delivery becomes better, right? So if she does not have any comorbidities like diabetes mellitus or any problems, then chance of vaginal delivery or successful vaginal delivery becomes better, right? So we have maternal factors, we have fetal factors, right? Three main things. We have to consider the mother, right? And we have to consider the baby. And the third thing is we need to consider the facilities available for the vaginal delivery, right? So just to say again, maternal factors are ideally she should not be over about 40 years of age, younger. Ideally, it's better if she's taller, not of short stature. Ideally, the BMI should be less than 30. Okay. And then she should not be having any morbidities at the moment. Right? And if you look at the past obstetric history, it's good if she has had a vaginal delivery at any point. If you look at her again at a past obstetric, if she has had a successful vaginal birth after cesarean, the chance of it being successful this time is also better. If she goes into spontaneous labor, the chance of a vaginal delivery is close to 80%, right? And sometimes maybe close to 90% if she goes into. So the chances of having a vaginal birth if she goes into spontaneous labor is very high, okay? Right? Normally, we will quote the figures of something between 70 and 75%. 3 in 4 women who will go into spontaneous labor will have a successful vaginal birth after cesarean, okay? Which is what we quote for the baby. On the other hand, 25%, 1 in 4, will have to go for an emergency cesarean section, where the morbidity goes up, okay? So that, of course, we have to remember. If you look at the fetal factors, what are they? Small baby, well-engaged head, right? And obviously without any fetal compromise, the good amount of amniotic fluid around the baby, right? That will give us most chances of having a successful vaginal birth. Then the institutional or the unit things, what are these? If we have a dedicated team who looks after patients and are trained to look after patients with vaginal birth after cesarean, then the outcome is better because they will have a trained way of looking at it and will not rush immediately for an emergency cesarean section if the need arises. So the more trained the staff is, the better the chance of having a vaginal birth after cesarean. Of course, we need to have also what is monitoring facilities. So the better our monitoring facilities are, the higher the chances of carrying out a vaginal birth after cesarean. And the third most important thing is not institutional, is that the mother should be consented properly and she should be determined or is oriented towards having a vaginal birth after cesarean. So she wants it, she's enthusiastic, and therefore the chances of vaginal birth after cesarean, because she's not going to say, okay, please, now enough, I have had enough, take me and do an emergency cesarean section, right? So if she's enthusiastic and then it increases. The other most important factor of a successful vaginal delivery, the success rate goes up, is due to, as I told you earlier, epidural. If you have an epidural analgesia in place, the chance of vaginal birth after cesarean will go up, right? Because of the pain relief, right? Things will, the chance of success are higher as opposed to a woman who has no epidural and is in more pain, right? So basically, these are the facts. There should be about 10, 11. How many did I get, children? Yeah?
13, sir.
Yeah, so there are about 10, 11. So I think I have got them all. So just look it up in books. There may be more, but these are the factors that will normally you need to talk about when you are. So remember, when you ask a question, just classify it into 3. What are the chances of a good vaginal birth? So you need to look at it and check in the mother, right? Of course, there are other factors which I forgot. If the uterus should not be having any scars, other scars, right? Not the simple lower segment cesarean section, right? Like whether there are any scars in the upper segment, scars where they have done myomectomy, but then if there are no scars or not a scarred uterus, and the only thing that there is a scar on due to the last cesarean section, the chance of vaginal birth is higher. Remember also, the chance of a successful vaginal birth after cesarean is higher when the incision is in the lower segment and it's transverse. There is lower vertical incisions, there the chance of vaginal birth after cesarean not is less, and therefore one of the main reasons for a successful vaginal birth after cesarean would be a lower segment transverse scar, which we normally perform in any normal uterine or a cesarean section. Is that clear? So those are the reasons that a woman can have a successful vaginal birth after cesarean. Right. Next is, what are the chances of failing? What are the when do we fail, or when do vaginal delivery settle? So there are some questions, right? So I'll just answer those questions before going to that. Can we perform instrumental delivery in VBAC? Of course. Now, instrumental delivery is something that is done when the cervical os is fully dilated. Very, very rarely we can do a vacuum delivery without a fully dilated cervix, about 9 centimeters during certain circumstances, where we can perform a vacuum delivery even with the cervix not fully dilated. But normally, most of the instrumental deliveries, almost all of them, and if it is a forceps delivery, definitely the cervix has to be fully dilated. Yes, we can perform a, because when the, but there is no routine instrumental delivery. That means VBAC, to shorten the second stage, we must do an instrumental. No, that is not there. So if it is indicated, the answer is yes. So what is the normal indication for instrumental delivery? If you want to shorten the second stage of labor, if there is a lack of progress in the second stage of labor, right? If there's a small obstruction and the head is not rotating, well, we can use vacuum, right? If the maternal effort is not there and she's tired and she can't push and then the baby is not coming down, you can use that. If there is fetal distress and there's a problem, yes, we can use the instrument. So there's no contraindication. Second question, does an epidural complicate labor? No, it does not actually. It is one of the best interventions that you can do in labor. Definitely it does not complicate labor, and I am a proponent. I mean, I think that all women should receive epidurals during labor, because it gives them a very pleasant, very good experience, and almost all the women have a very comfortable delivery with epidurals. So therefore, it is a good thing. I think one of the best things that is there in obstetrics, and it does not complicate labor. And furthermore, what you have to understand is the chance of instrumental delivery is not higher, because now the epidurals are very low dose, or they are called walk-in epidurals, because the motor functions are not impaired, only the sensation is knocked off. You can feel the tugging and pulling, but not the pain. And therefore, earlier years, when the motor functions were impaired, when the epidurals were high dose, then there was an increased incidence of instrumental delivery. No longer, because we are giving now, or the consultant or the anesthetists are giving low dose epidurals, and they are extremely effective and extremely good if given properly. could you please explain the absolute indications for cesarean surgery? Any indication that requires a cesarean section electively, if there's a large lower segment cesarean section, fibroid, then it's not different. If the head or the placenta part is over the fibroid and the fibroid is lying below the placenta part, then in the lower segment, then of course you have to go for a cesarean section. Then if there is a multiple pregnancy with the first twin in transfers or anything else, then you might need to go for a cesarean section. If there was a myomectomy performed with opening into the cavity, then of course probably it's best if you go for a cesarean section. A classical cesarean section in the past would mean that it looks like, sounds like, usually it is a indication for a cesarean delivery, right? So those are the indications that, so this, most of these indications will also be not absolute, right? So you need to decide this way, case by case, case by case. So you cannot do a blanket absolute contraindications, which is a very old way of looking at things. So you need to individualize things different, right? Okay. Please do a session on fetal screening and fetal monitoring from the time of conception up to the time of delivery. Right, okay. Okay, I mean that is a very, very, very long session. So what I'll do is, fetal screening is basically the initial, first trimester screening, then the anomaly scan, and then during delivery, of course, we have to speak about, it's not screening actually, it's monitoring. Then we have to do a CTG. That I will do as one class later on. Oh, I am sorry, did not mean to send this text now. Okay. No worries, no worries. Puta or do, I don't know, but you are living in the future and I like that. Okay. So that's all for the moment. Right. Okay. So where were we actually? Give me a moment. No, no. No, okay. Right, okay. So, right, okay. Where were we? Kavisha, where were we? What did I just finish?
Sir, you're talking about the indications for instrumental delivery in VBAC.
All right, okay. So let's look at the problems or the chances of having an unsuccessful vaginal birth after cesarean. We spoke about what are the things that there is if a vaginal birth can be more successful, right? The chances of the vaginal birth being more successful are the ones that I spoke of. So about 10, 11 facts, right? Then let's look at the things that might cause the vaginal birth after cesarean to be unsuccessful. Okay, we try, but we don't get there. Okay, number one, if we look at the mother or the maternal side, if she is obese, overweight, over 30, BMI is over 30, the chance of it being successful becomes less. If she is of short stature, chances become less. If she does not go into spontaneous labor, okay, then the chances become less, right? Well, if a woman goes into spontaneous labor with a past cesarean section, the chance of VBAC becomes more successful. Next is, if the cervix is unfavorable at the start, right, and you are trying to go for a VBAC, especially if the cervix is less than 4 centimeters dilated, the chances of VBAC, having a successful VBAC, is less. If the woman requires induction or augmentation, right, that is, you try to give oxytocin, which is maybe not a very good thing, you have to do it very, very carefully, or that is augmentation. What is augmentation? Labor is happening, but it is not enough. So you need to give something to increase the contraction. That is augmentation. What is induction? You are trying to start something new, or you are trying to push into labor. Okay. So if the woman needs induction or augmentation, the chance of a successful vaginal delivery becomes less, right? If the baby is more than 4 kilograms in other countries, probably in our country, we should be thinking about maybe about 3.5. Okay. If the baby is large, the chances of having a successful vaginal delivery goes down, right? Then, if the maternal age is higher, the chance of successful vaginal delivery will become less. If you are looking at the previous cesarean section, one of the things we need to consider is, did she have a cesarean section in the first part, or did she have a cesarean section at the last minute where there were problems, that is almost at full dilatation now? And if she has had a cesarean section, right, where she has progressed, but then everything has got stuck or had a problem, right, that problem might recur. And therefore, that if the cesarean section was after a lot of progress of labor and it was due to dystocia labor, right, that thing has not progressed even after cervical dilatation and everything, and then they had to go for a cesarean section in the past, the chances of having a successful vaginal birth after cesarean this pregnancy becomes less. If the woman in the previous, because this is something that has to do with the topic which I discussed earlier, if the woman has had a cesarean section for fetal distress, especially in early part of the labor, then the chance of a vaginal birth after cesarean becomes higher this time, because her uterus is going to behave like a nulliparous uterus. Now, what is the difference between a uterus that has gone into labor and has delivered or almost delivered in comparison with the uterus that has not gone through the whole contractility process, and that the plasticity and everything is different? If the woman has had a previous cesarean section in the last stages of the, almost with full dilatation, then the uterus is going to behave like a multiparous uterus. It's going to labor less to do the same amount of work, but the contractions are not strong, and therefore the chances become less. If the woman has undergone a cesarean section, when the cesarean section was done in the early stages, then now it's going to behave more like a nulliparous uterus, and therefore the contractions will be stronger, and the chance of a vaginal birth after cesarean will become more. Do you all understand? So that is something that you need to remember as well, right? So if the baby is large, if there is malpresentation, if there's during labor, if the progress is slower, right? If she has no epidural, if the monitoring may not be very good, if the staff is not very well trained, right? And all these factors will contribute towards the unsuccessful vaginal delivery or vaginal birth after cesarean, right? So remember the maternal factors: obese, short stature, right? Small pelvis, right? Large baby, previous unsuccessful vaginal birth after cesarean. All these will contribute towards a unsuccessful vaginal birth at this point. Is that clear? Right. So from there, let's move on to a few things that you need to know, just know. Okay. Number one, we have to know during this procedure is what we call lower uterine segment thickness, which is something that is been coming up, right? First thing is lower uterine segment thickness is what? You can measure the thickness of the lower segment by ultrasound scan. So still there are no absolute what it is recommendations, but it is thought if the lower segment thickness is less than 2 millimeters, okay, very thin, the chance of uterine rupture is higher, and therefore can contribute to problems in a vaginal birth after cesarean, and therefore it might be better if you go for an elective repeat cesarean section. Is that clear? Lower segment thickness of more than 4 millimeters will contribute towards a safer vaginal birth after cesarean. Is that clear? So that is something that you need to remember. The next thing is the place of induction and augmentation in labor or in vaginal birth after cesarean. What does that mean? Now, if the woman does not go into spontaneous labor, is it all right for us to induce, or is it all right for us to augment? Which is a question that you need to remember that will be asked for you. If you do start, now how do you induce? There are few ways which you can induce. Number one is you can do an artificial separation of the membranes when we are thinking of delivery. Okay, you put your finger in and you circle it around, the membranes will be separated from the cervix. It is thought to produce natural prostaglandins, which can increase the chance of a vaginal delivery. That can be done, right? So there is evidence to say that can be more successful to increase the chance of vaginal birth after cesarean. That is a form of induction that can be used safely, right? So there is enough evidence for that. The second form of induction which we can use safely is just doing an artificial rupture of the membranes. So if a woman, if you want to induce labor, if the woman has not gone into spontaneous labor and she wants a vaginal birth after cesarean, what are the safest ways of induction is what? You do a rupture of the membranes, then you wait for spontaneous contractions to occur. And if the spontaneous contractions occur and she goes into labor, then you can wait for delivery. So that also is a safe way of induction. And in that instant, if she doesn't progress well, the use of augmentation with oxytocin is usually, it is called, you have to have a judicious use of oxytocin during labor with very good monitoring and for it to be safe. However, there's a controversy as to whether you should be using oxytocin for labor. So if you have very good monitoring facilities, if the theater is standing by, theater staff is trained to detect uterine rupture, right? Then of course, maybe a small amount of oxytocin may be all right, but that has to be very careful with. But one of the ways which you can go around it and which our units sometimes practice is if a woman wants a vaginal birth after cesarean and she doesn't go into spontaneous labor, one of the ways which you can go about it is if the cervix is open enough, you can just do an artificial rupture of the membranes and then wait for the woman to go into spontaneous labor. And we should have discussed prior, look, we will wait for 4-5 hours. We don't go into labor, maybe we should, without using augmentation or oxytocin, we will go for a cesarean section, right? So that is one way. The third thing which most of the units in the world will not use, is to use prostaglandins. Because the prostaglandins, and especially things like misoprostol, can increase the chance of uterine rupture, right? Than just the two methods which I spoke about. Plus other things like Foley catheter might be more safer than prostaglandins, of course, right? So, but usually if you prostaglandins, it is thought that it is better not use them, although several units may be using prostaglandins to start off labor, but even for induction, right? However, it is thought that prostaglandins might increase the risk of rupture of the uterine scar more than all the other methods, right? So that is the place which we have for induction, for augmentation, and the methods of induction. Is that clear, children? Right. Next, what we need to decide is about placenta previa and placenta acquita. Okay. Now, what is the most important thing as MBBS students, as intern house officers to remember is, right? If there's a scar on the uterus and the placenta is anterior, right? It is a past cesarean section. The chances are higher if the placenta is underlying, or if you look at it the other way, overlying. Okay, depends on how you are looking at it, right? So if you sit in the uterus and look at the placenta, then the placenta is overlying. Okay, if you are looking from top of the tummy and the placenta is underlying the scar. So depending on who is looking, the baby probably is looking at an overlying placenta, while we are looking at an underlying placenta. Okay, from the scar. So now, if the placenta is sitting right on the scar, the chances of invasion is higher. Why? Because the placenta is an organ which invades. Okay, where there's trophoblast, which has to get its nutrition, and therefore it invades into the maternal uterus, but only onto the top layer and the blood vessels, right? But when there's a scar, right, it is not normal myometrium that is there. It is connective tissue. And therefore, that connective tissue there has lost its ability to resist invasion. A normal living cell resists invasion. So the placenta, even if the trophoblast is trying, the myometrial cells will keep it at bay, right? But when there is scar tissue, the resistance is less. So therefore, the trophoblast will start to grow into it. And therefore, we call it what? An abnormally adherent placenta. The chances of abnormal adherent placenta will increase with each cesarean section, past cesarean section. So starting from about 10 or 6-7%, when it 5-6 cesarean section, it goes up to about 67-70% of abnormally adherent placenta. Very, very, very high. Okay. And what happens when there is abnormal adherence? The placenta simply won't come off. So when you try to do a cesarean section, right, or a normal delivery, once the placenta is not getting delivered, if you try to deliver the placenta, part of it will come off and there will be torrential bleeding. And the other thing about invasive placenta is this: the placenta can go through the serosa and climb into the organs that are surrounding it. It can go into the bladder, it can go into the sides, right? And it can go into the wall, pelvic wall, and especially it can invade the bladder. So those are abnormally adherent placentas which need expertise in tackling, because sometimes you have to go in and take off part of the bladder as well with the placenta, right? So remember, at 20 weeks, if the placenta is on the scar, anterior, on the scar, then we have to think there is a possibility it can end up as a placenta previa or a placenta acquita with a scar. And therefore, we need to reschedule another ultrasound scan between 32 and 34 weeks, okay, to see whether the placenta is still there. If the placenta is just on the scar, then we have to do investigations to find out whether there's abnormal adherence. What are these investigations? Number one is we need to do a Doppler to see whether the placenta is a placenta acquita. The second thing which you can do is we can do a MRI to find out whether it is invading, and especially we will need a MRI if we think that it is going into the bladder and bladder wall and bladder mucosa as well. Okay, so these are the things that you need to consider when the placenta is underlying the cesarean section scar. Got it, children? Right. The next consideration, how do we manage labor? Okay, so that is something that you'll be often asked, and therefore you need to remember when you're talking about vaginal birth after cesarean, you need to know how to monitor and do how to manage during the delivery period. Number one, it is very important if she has gone into labor for a IV access, right? There should be a blood bank ready. There should be blood. There must be a theater for emergency cesarean sections, right? There must be good way of monitoring, fetal monitoring, especially a CTG, right? And the staff must be trained to recognize uterine scar rupture. Is that clear, children? So you have to ask what conditions there must be for in the labor room for a woman to have a vaginal birth after cesarean. Remember those things. We need to have good monitoring facilities. We need to have access to blood, good blood bank, a theater standing fine, and the most important feature is what? There must be a well-trained staff, that is including y'all children if you are going to be in the labor rooms, to recognize uterine rupture. Okay? And what are these features of uterine rupture? Number one, even if she's on an epidural, right, uterine rupture will cause pain in the lower segment if you palpate, even if she's on an epidural. That is number one. Number two, the CTG will start to show abnormalities in rupture and dehiscence as well. Now, what is the difference between dehiscence and rupture? Rupture is when the serosa of the uterus is not intact. The serosa, right? You have the endometrium, the myometrium, and the serosa. Yeah. So when that is broken, that is rupture. Okay. Dehiscence is all the layers of the things are ruptured, but not the serosa. So that is dehiscence, scar dehiscence. Okay. Scar rupture is when the serosa is gone. Or when the rupture extends into the bladder or into the broad ligament, that is also called rupture. Okay. So therefore, number one is there may be CTG abnormality because there has to be continuous fetal monitoring. It can initially be dehiscence. The first may be just fetal tachycardia, right? And then with rupture, you will have late decelerations, early decelerations, fetal bradycardia, all those prolonged decelerations, all those problems can come up. So fetal CTG abnormalities or fetal heart rate abnormalities should be detected. Number two, there will be pain, even on an epidural in the lower segment, continuous pain. Third thing is, between contractions, if she's not on an epidural, there will be very severe tenderness on palpation, right? The fourth thing is, she can have sudden onset of vaginal bleeding, right? 5, she can start to have blood in her urine because the rupture may have interrupted or gone into the bladder as well, right? If there was a bladder and uterus was adhered to each other due to the past cesarean section, when the scar tears, the bladder also can tear at the same time, right? And then you can have hematuria. She will have blood with a urine, right? The next, the presenting part will suddenly disappear. So you are doing vaginal exam, the head was there, suddenly you do it and the head has gone. Where has it gone? It has gone into the abdominal cavity. Okay, so the presenting part disappears. Next, you might find then she will have very severe pain during the rupture, and that will be very, very severe. Next is she can collapse, she can go into shock. The blood pressure will fall down, the pulse rate will go up. She will have maternal tachycardia. Okay, and then she will collapse. She will go into shock. Cold peripheries, blood pressure will fall down. She will not respond quickly, right? And those are the features of collapse and shock which she can have. And then, so those are, and then you might be able to feel fetal parts in the maternal abdomen here and there. The chance of the baby dying in rupture is about 6 to 8%. If it ruptures, if you don't take it out quickly, there's high chance that the baby is going to die. 1 in 10, right? So that is number one. Okay. So there must be a well-trained staff to recognize the features of uterine rupture, which I just told you. Is that clear? So these are the things that you have to know as a student to be able to answer and of course monitor patients in the labor room who are undergoing vaginal birth after cesarean. Right. So these basically are the things that we need to cover or understand in vaginal birth after cesarean. Right. So I've just given you an overview. Right. And basically, if you summarize the whole thing, okay, first of all, you have to understand the definitions. You have vaginal birth after cesarean, you have elective repeat cesarean section, and you have an unsuccessful failed vaginal birth after cesarean. 3 things you need to understand. The second principle that you need to understand, children, is a vaginal birth after cesarean is very safe. Chances of if she goes into spontaneous delivery is close to 80%, sometimes 90%. Even if she, and chance of having a successful vaginal birth is always quoted as 72 to 75%. Okay. The chances of an elective repeat cesarean section, the mortality is higher when compared to a successful vaginal birth because you have the mortality of a successful vaginal birth is 4 in 100,000. Mortality of a cesarean section in itself is about 13 in 100,000. Okay. However, what you have to remember is the chances of having there is more maternal morbidity in a failed vaginal birth after cesarean or failed unsuccessful vaginal birth after cesarean. The morbidity is about 3.8% as compared to 0.8% in a elective repeat cesarean section, right? Do you all get it? So that is one thing you need to consider as an overall review. Next, you need to know what the contraindications are, which I have discussed. Next, you need to know the factors that influence or for the woman to have a successful vaginal delivery, a vaginal birth after cesarean, which I have discussed. Next, we discuss the chances of having an unsuccessful vaginal birth after cesarean, right? Next, I discussed a few things like the lower uterine segment scar, the thickness, but the evidence is for the moment coming up only. So for the moment, by just looking at it, we might not be able to predict that the woman is going to have a rupture or not. So therefore, our management decisions at this point of time is not based on doing a scan and checking the lower segment and say that yes, the woman might have a higher risk. Okay, but that might come up later. Next, we discuss the chances of placenta previa and placenta accreta or abnormal if the placenta is sitting on the scar. Is that clear? So therefore, at 20 weeks, if we see it, then we will need to repeat it between 32 and 34. And if we are suspecting it more, of course, an expert at ultrasound scan, it's the same thing as MRI, the results. But of course, if you want, you can do an MRI to see whether it has climbed into the other organs, right? And then, of course, you will need a lot of expertise if you want to do a patient with placenta accreta, because she is anyway going to end up with, probably going to end up with a cesarean hysterectomy, which needs a lot of experience and technical skill to do a or do a perform a cesarean hysterectomy for a woman with placenta accreta. Then we went on to what? We went on to looking at how a woman is going to be managed during labor, right? And at the same time, what the dangers are for oxytocin, prostaglandin, and what we can do, the best is if we can do without those. And usually we do not use prostaglandins for previous cesarean section. And definitely not misoprostol, remember, is not used. The chance of death might increase to try and induce labors in women. And definitely for preterm labor, if the baby has died inside preterm labor, then of course we do not definitely use misoprostol because that can cause death in a woman. And I remember several places where misoprostol was used without knowledge and where death of the woman occurred due to rupture. From there, we moved on to what? The recognition of uterine rupture during labor, right? So that we went through comprehensively. So now, what you have to remember is, what you all please do. So this is homework for you all children. Where is the material that you want to go through, right? To look at this from what I have told you. Number one, please go to the Royal College of Obs and Gynae, and they have a very good guideline on vaginal birth after cesarean. Okay. Second is, children, go to the Royal College website and look for the patient information leaflet, right? That will give you the answers to almost all the questions a woman can ask regarding a vaginal birth after cesarean, right? In simple language. So please read through that. That'll be extremely useful for you to be able to counsel and talk to a woman truthfully about vaginal birth after cesarean, right? So those are the two important documents that I would want you all. This is especially for the postgraduate children, but from your side also, it'll be good if you can look at those documents. That will give you a comprehensive overview, and the summary is also there for you to understand more into this topic, right? So that probably concludes Mudra and the homework for you all, right? So after this, go and look at it. Just write 2 columns for yourself, children. What it is? Because what we need to compare is vaginal birth after cesarean, you have to compare with elective repeat cesarean section. So what you do is, there has to be 4 boxes. Advantages of vaginal birth after cesarean, right? So roughly, what are the advantages of vaginal birth after cesarean? It's shorter hospital stay, quicker recovery, less morbidity, right? The chances of the baby having transient respiratory problems. Now, what is that? If the baby is just lifted out, because the chest compressions are not there. So because of that, when there's a vaginal delivery, there is more chest compressions in the baby while it's coming out. So the baby's chest muscles are more practiced when it comes out to breathe on its own. While the baby is just lifted out in a cesarean section, sometimes because of that, there may be transient respiratory distress, but it is not too great in both. So it's not very significant, but that is something that the advantage is not having that in a vaginal birth after cesarean, while the transient tachypnea can be more in a baby with elective repeat cesarean section, right? Then the second advantage, so if you do an elective cesarean section less than 39 weeks or between less than 37 completed weeks, then chances of having preterm problems is higher, right? So you have to remember that as well. So while a vaginal birth after cesarean, most of the time we will wait until 40 weeks for the woman to go into labor. The next thing is, very, very rarely, while waiting for the woman to go into spontaneous labor, the chance of intrauterine death increases. 10 in 10,000. Yeah. Right? So therefore, there's a slight increase in the chances of having intrauterine death if you wait for the woman to go into spontaneous labor in a patient who has had a previous cesarean section. The reasons are not unknown, but that is what the evidence is there. So you have to remember that as well, right? So what you do is, children, take two things. What are things? On one side, we have vaginal birth after cesarean. Then you have another thing, you put elective repeat cesarean section. Okay. Then on one column where there is vaginal birth after cesarean, just list out the benefits of a vaginal birth after cesarean, advantages and disadvantages, right? The advantages you divide into two, maternal, fetal. And the disadvantages also you divide into maternal, fetal. Okay, I have said most of them, but you just list them down for your purpose. Then for elective repeat cesarean section, maternal benefits and maternal disadvantages. Fetal benefits and fetal disadvantages of elective repeat cesarean section. Is that clear, children? So then I will answer the questions because I have covered almost everything. I think everything except just that Wagua which you have to do for yourselves, right? So then I will look at the questions. Right. Wouldn't stronger contractions result in higher chance of rupture? Yes, but the chances of, there is nothing about stronger contractions. The proper way would be the contractions need to be stronger anyway, but they need to be directed contractions, right? Where the contractions should be well orchestrated, well, so the contractility is well organized, right? And therefore that will cause the expulsion of the fetus better. So contractions have to be strong. Weak contractions is not going to deliver the baby. Okay. So the stronger the contractions, better. But what is needed is good contractions, right? That gives us a result. Then relaxation, good contraction, relaxation. So rupture is not due to the contractions. Actually, the rupture is due to the problems in the scar itself, right? So the weaker the scar, the thinner the lower segment, the higher chance of rupture with any contraction. It might not be even a strong contraction. Okay. Using induction and augmentation cause uterine rupture in VBAC. Yes, the chances are higher. It doesn't say it does, but if you induce or if you augment, right, the chance of uterine rupture becomes higher than using no induction and no augmentation, which means if she goes into spontaneous labor, which we discussed, the chances are higher that there won't be a scar rupture. If you don't use oxytocin or any form of to augment and labor goes on very well without dystocia labor, then the chance of scar rupture is less, right? So therefore, you need to have a very low threshold for a cesarean section, especially if the labor is not progressing well, if the contractions are disorganized, right, discordant, if there is hyperstimulation for some reason, if you are using augmentation, right? Therefore, you need to go for an early decision for a cesarean section without causing rupture. Do we need to offer the mother with PPH prophylaxis? Any labor, now we always use active management of the third stage for the prevention of PPH. So that is, anyway, it is there. Okay. Right. So I have covered all the questions. Anything else that you want to talk about? Any questions? Shamod, any questions? No? All right. Excellent.
Yes.
Question. Could you please have a class on normal labor and special circumstances in labor? Right. Okay. Yeah, we'll have a class on normal labor because I think that is important because we need to discuss about the principles of labor. principles of using oxytocin, which a lot of people are unaware of the principles, right? So we'll have a class on that. So yes, we'll do that. Okay. Any more questions? Shall we wrap it up? So next time, what do you all want to do? Because I'm going to, next time is gynecology, right? So probably next Wednesday, we will do gynecology. What is the topic that you all want me to cover in gynecology? Quickly type in any topics if you want to. The last time someone typed in PCOS, I thought it's a difficult one. That's why I did it. Anything you all want? Contraception, young man. Contraception. Young man, I thought you know everything about contraception and not, but anyway. It's not a difficult topic, child. Okay, I will think about it. All right. I think the young man is about to get married. Sir, could you please do a session on gyn obs related endocrinology? That is a very boring topic. Right. Yeah, can do. Okay. Miscarriages. Okay. Gynecological malignancy. Subfertility. Right. Fine. That's uterine prolapse. Okay. Just don't give me the easiest of topics which you can understand. Just give me topics which you find difficult to get your head around to. Incontinence, okay. Right, that should be enough large list for me to choose from. So I will do one of those next time, right? And then probably hormonal control is very difficult to remember. Hormonal control of what, Puta? What hormonal control of what? Can you type in your answer? All right. Okay. Doesn't incontinence and PV prolapse go hand in hand? Actually, it goes womb and vagina, not hand in hand. But anyway, it's like this, children. Now, vaginal, uterovaginal prolapse and incontinence are same thing and not the same thing. These are all pelvic flow problems other than urge incontinence. So stress incontinence and uterovaginal prolapse are pelvic flow problems, but however, they might not coexist. They can be independent problems. So therefore, yes, this are so that we will discuss later, no problem. Gyn obs related hormonal control. Yeah, you mean the hormones that we use, menstrual cycle related and pregnancy hormone. Yeah, okay. That is something that we will discuss because there's a lot of controversies there. So we will discuss that definitely. So I think that is a lot of topics. Anyway, there are lots of weeks ahead. So we will discuss them one by one, don't worry. I think immediate thing is, I think we should discuss labor ward, I think, right? So next time I will discuss the principles of managing a normal labor. And then there it will, then we'll have to take a separate class on CTG, right? And for fetal monitoring in labor. I'll take another class about how to manage a normal labor in the sense with partogram, how to do a proper monitoring. All that we will do one more the class, right? Okay. Okay, children, right. So then till next Wednesday, okay? So good night.
Good night, sir. Thank you.
Sir.
Bye. Good night.
Thank you, sir.
Thank you very much, sir.
Okay.
Thank you, sir.